I
Since
think
we have two speakers today with.
Yes, I think we should get started. So I will introduce the person who needs no introduction, Dr. Dave Thomas, who's going to tell us about elimination of hepatitis C in HIV positive patients. Thank you, Dave.
Thanks a lot, Eileen. I think I've successfully put my slides up. Can you confirm before I spend the next 20 minutes?
Yes, they look great.
Okay, great. So thanks a lot. Yeah, it's we're really glad to kick off the hepatitis talks and to specifically address this issue of eliminating hepatitis C in HIV positive individuals. I have these disclosures which don't have anything to do with this talk, and I wanted to start out just kind of defining what is meant by elimination, because it's not always, I mean, we sort of have a sense it means like getting rid of something, but there's a specific meaning to it at least when the WHO talks about it in sort of public health parlance. And so elimination is somewhere in between eradication. Eradication is like what we did with smallpox, you know, it is gone. And if we stop trying, it'll still be gone. It's just gone. And that's eradication, which so far we've done with smallpox, maybe dracunculiasis someday, but not very many infectious diseases. And then there's control, which is just like we put public health pressure on something and it's under control as long as that's sustained, but it remains a problem in other parts of the world, for example. And then elimination somewhere in the middle. And it has a very specific definition, differs, for example, for HIV or malaria or tuberculosis. And interestingly, those three and hepatitis are the WHO sort of challenge to eliminate them is indexed to the year 2030 as part of the UN Sustainable Development Goals. And so that's kind of if you will, sort of the authority behind this. For the hepatitis bit, it's defined two ways. So when they say, what is elimination? It means we're either going to reduce incidence, new cases of hepatitis C or new cases of chronic hepatitis B. We're going to knock them down by 90% from 2015 to 2030. So that's the first indication of eliminating. And then for the second one is to reduce the deaths caused by these two viruses by 65%. So once again, 2015 down to 2030. So with hepatitis B, 884,000 deaths, hep C 400 down to 209 and 140 respectively. So I'll be focusing on hepatitis C in this talk, and I'll be talking about those two indicators when I'm talking about eliminating and talking about 2030 as our goal. Now, if those are the two ways we define elimination, then we have these 5 ways to achieve it. And then for each of these 5 interventions, we have targets, which have to do with how much of these interventions will be applied at a population level in order to achieve elimination. So with, and logically, they can be broken down as to whether they're focused, targeted, if you will, on the incidence goal or whether they're targeted on reducing mortality. Logically, coming up with safe ways to give injections is one of the major measures to reduce new, especially hep C infections. And that's supposed to go from 95 up to 100% by 2030. And that just refers to like reuse of needles and syringes and injections used for medical procedures. You think, well, it should be already 100%, but it's not, of course, around the world. And that is the leading way that hepatitis C is spread worldwide. You know, we think it's injection drug use, but worldwide, it's unsafe medical practices. The screening blood donations, you'd also like to think is already at 100%, but it's not. And so by pushing that, the goal is to push it up to 100%. there's a fuzzier goal here around expanding harm reduction. And this obviously is targeted at persons who inject drugs. And this metric has to do with the number of sort of loosely defined as syringes available per person per year. So you can imagine that if you only had 27 available for a whole year, that would not be a lot, but that was the case in 2015 on average. Obviously, some people had none, other people living in the area where needle exchanges services have as many as they need. And then they want to drive that up to 300. I have no idea how they came up with those measures, to be honest, but that's what they are. And then with mortality, with that 65% reduction in mortality that I referred to, that's going to be achieved, of course, by testing and treatment, by curing the people who have hepatitis C, or with the case of hepatitis B, just getting them on treatment. And that's supposed to go, 20% of people are aware of their status in 2015, all the way up to 90% being aware of their status. So massive expansion of testing necessary. And then for treatment, for that to be 80% of those that know that they're positive. Okay, so these are reminiscent of the 90s that you're already familiar with HIV to achieve HIV elimination. These indicators and their measures have come from this modeling exercise that was done, where, for example, first looking at incident infections, and we consider the status quo would be not doing anything. So this is what would happen if we did nothing new. There'd still be a slow reduction in new Hep C cases, because around the world, there's a gradual appreciation for the importance of bloodborne pathogens, and there's already been some engineering controls with needles that draw back and you can't reuse them, and that makes medical practices safer. But if you want to achieve the elimination goal shown at the with that pink dotted line within 80% reduction, then you have to add to that status quo expanded blood safety and infection control. So that's just really pushing those needles out to where 100% of them are done in a safe way. And then also that expanded harm reduction, 300 syringes per person per year. And notice that these, the biggest bump, the biggest bang for your buck, if you will, comes with the expanded blood safety, logically, because I said that was where most new infections derive. So that's where you're going to get the biggest impact. But then another bump from reducing infections among persons who inject drugs, and then even a little bit more of a bump by expanding the testing and treatment, though that's focused on the mortality outcome. Because you can't get hepatitis C from someone who's been cured, then that also will have will also in turn reduce incidence. Okay, so that's the way we're going to reduce. Now, I said 90% reduction overall in incidence, which is true. Since then, WHO has clarified that they mean the Hep C incidence will come down by 80%, HBV 95, average of 90. Don't ask, and don't get me going on that. So, okay, so that's why that somewhat dissonant message. Now, what about this reduction in mortality? How are we going to reduce mortality by 65%? Well, if we do status quo here, there's no reduction in mortality because people are going to keep aging, and the 58 million people that have hepatitis C will die of it. And so there's no reduction anticipated by status quo. If we expand some of these measures meant to stop new infections, you get a little bit of a reduction in mortality, because once again, if you have fewer new ones, then you're going to have fewer people in 10 or 15 years to have problems from hepatitis C. But the big impact, of course, is expanding testing and treatment, because it's a curable infectious disease, and cure markedly reduces liver cancer and liver failure. So that's how we're going to get to the 65% reduction, and that's where those metrics have been derived. Okay. So that's just big picture. That's just elimination. And so far, I haven't talked about my main topic, which is HIV positive populations. So with those general principles, then there's this sub issue of how to eliminate certain populations. And HIV positive individuals are one that gets special consideration, so-called micro elimination. And as you might gather, there's certain reasons to think that that's going to go better, and maybe a few that it might not be as easy as in other populations. But mostly, there's reasons to think it will go better because, first of all, it's certainly important. There's more disease impact, and we know that the treatment will work in that population just as well as in HIV uninfected. There's a smaller number of individuals, and most importantly, there are already many individuals who are in care, and many of the hepatitis C HIV co-infected persons already are engaged in care because of their HIV, and therefore the testing and treatment part comes easier because there's access to all those systems. A few reasons to think it might be more difficult, for instance, higher rates of reinfection, and some of the co-infected people are very difficult to reach, such as persons who inject drugs who are duly infected in some parts of the world. So overall, it's thought that we're talking about somewhere in the neighborhood of 2 to 3 million persons who are duly infected with HIV and Hep C worldwide. And logically, that's not evenly distributed. It's concentrated in places where drug use is most an important reason for HIV acquisition. So wherever you get HIV from Hep C, often you've already gotten Hep C because it's a more transmissible bloodborne infection. There are already data about this, about how to achieve this microelimination, and some of the first data have come from the Netherlands, and there's really a couple reasons. One is most of the people with HIV are in the Netherlands are claimed to be accounted for within this Athena cohort. So they have the perception that most everyone that's positive is under study, and so that they can discuss their fate, if you will. That cohort is a high percentage of acquiring HIV from men having it from other men, and about 15% among persons who inject drugs. They made DAAs available with no restrictions. So imagine a country where that's the case, and free of cost. And now they have data through 2019. And then on the right, you can just sort of see sort of the breakdown of the 23,000 some HIV positive individuals, and the 10% that have some HCV RNA, those who were judged to be spontaneously cleared, and then roughly 1,471 who were the subjects of this study because they were RNA positive and in care. They've had a number of publications talking about different elements. I'll show some of the more recent data. Look on the y-axis here. What you're seeing is the percent of the population by these two risk factors who are HCV RNA positive. So in the left is the MSM, and I circled the axis because you have to use a different axis because, of course, most persons who inject drugs are HCV positive, and it's the exception with the MSM population. But nonetheless, you can see that the viremia percentage was rising as there was greater and greater disinhibition and more risk taking among MSM linked to heart and just perceptions of safety. And then all of a sudden, this precipitous decline in viremia that's temporarily linked to the availability of treatments for hepatitis C. So marked decrease in viremia, but not completely down to zero, but a really major drop. Likewise, although this thing is hiding, there we go. Likewise, with persons who inject drugs, precipitous drop in association with this expanded testing and treatment. within the country in the Netherlands. So that's an exciting indication that treatment, that there is some evidence for elimination occurring. Okay, let's see. No, that didn't do anything good there. That was a bad thing. Let's see if we can go down. There we go. So then the other part of it that's interesting is they've been tracking new infections and categorizing them as to whether they're first infections for the first time, whether it's HCV seroconversion or whether it's a reinfection. And you can see that new infections also dropped. So with expanding treatment, so treatment of people with Hep C prevented new Hep C infections because the reservoir, the number of persons from whom you could get the infection dropped. So treatment as a form of prevention was actually, this was one of the first places where that was shown. Now we have similar data from Switzerland, from the Swiss cohort study, and from France. So in Europe, there's evidence that that there could be elimination of hepatitis C in HIV positive persons in association with these with this expanded DAA use. But the fact that there's still new infections occurring, okay, albeit at a lower rate, does present a little bit of a pause for our initial exuberance that this was going to be extremely effective, because of course if we continue playing this out, it shows that whereas that you're reducing the prevalence substantially, the group that's spreading it aren't necessarily the ones that are getting cured. And so these transmissions still occur and could threaten long-term the prospects for elimination. Likewise, if we turn our attention to Baltimore, there's both a half full and half empty story. The status of persons who inject drugs in Baltimore is largely reflected by the ALIVE cohort, where individuals are sort of out in the community, if you will. So they're not actually coming to a clinic. Some of them might come to Chase Brexton, might come to Jai, might come to our clinic, but they're not necessarily there. They're in the community, and their status there is sort of representative of how a person who injects drug might be. And so we've been tracking them along for years and years, as many of you know. And now if we just look in this figure, and these data were put together by Javier Cepeda and Shruti Mehta. Now we're looking we have two axes here. On the Y1 axis, this is the FibroScan score. This is the average, the proportion or the percent of individuals in the cohort who have cirrhosis over time. And then on the Y2 axis, in the red line, is the viremia status of the cohort. So the viremia status of the cohort is pretty stubbornly around 90%, right, for through from 2006 on. There's not many people being cured. In fact, it's actually 100% here because we sort of fixed it at that to say, okay, what happens if we start at 2006 with everyone that's a treatment candidate? No one really goes on treatment during the interferon era, but then all of a sudden around when the availability of the DAAs come, you can see viremia declining to where now only about just under half of the cohort is still viremic. So that's a half full, half empty kind of story, because of course this could be zero. We have the tool to drive it to zero. We have treatment and we have testing for sure, but we've done 50%. In the meantime, the cirrhosis prevalence in the cohort was actually rising until the DAAs came out and has been steadily falling since then. And there's a lot of things that can bias a study like this. So one way to look at it is to kind of just color the liver FibroScan scores. So this is a natural log transformed FibroScan scores and of the entire cohort. But they're colored two different ways according to whether or not someone's viremia status at their last observation is either cleared in the blue or still positive in the red. And you can see that there's really no evidence that these are any different. These two groups are any different after adjusting for HIV, alcohol, and age and other factors. They're really very similar until that very binary event occurs. You either get cured or not. So we think that sort of at the population level, this is an indicator that the treatment is working, is reducing cirrhosis incidence and prevalence in persons who inject drugs in Baltimore, but also raising questions about how we're going to, by 2030, finish the job. And then likewise, of course, with Richard and Mark and Shone and Shruti and many other people who have been working in the Bartlett specialty practice and monitoring Hep C treatment uptake. You know, historically, it was pretty abysmal, and there were a lot of reasons for that. And then the last time Richard's told me, this is the most recent data that Shone put together, showing that the percentage of individuals across this cascade of those who were available for treatment, those who went to see a provider, sometimes even themselves being referred for treatment, and then those that were evaluated, prescribed the medication, treatment was initiated, and then were cured. So there's still a cascade, largely down to people missing visits, and not down to the drugs not working. The drugs work great if they're taken. We have a pretty low rate of reinfection so far in our cohort, but obviously that's a story that needs to continue to be told and monitored across time. And when we consider what might threaten, I already mentioned in Europe, this is the threat for microelimination of Hep C in persons who, in HIV positive individuals. And so this is a meta-analysis of some of those data, and certainly, interestingly, especially in some of the MSM populations, even more than persons who inject drugs, reinfection has jumped out as an important threat to elimination, since you can be infected again even after you're cured. And then there's this subtle issue here in the United States, where instead of reducing incidence by 80%, we've actually doubled incidence. So we've gone up we're up to 200% instead of down by 80 if you go from 2015 to 2019. And if you project that out, that same incidence out because of our opioid epidemic, then we're not even close to eliminating Hep C in the United States. And no one's talking about us actually achieving this. And so people like Andrea are working on vaccines and other tools, because what we've been doing to date, namely DAAs, isn't stopping Hep C incidence in the United States. It's the opposite. It's going up. Okay, COVID was certainly a threat. I'm not going to get too much into these data, but they're worldwide. Many of the things that are being done for Hep C, like testing and treatment, were all suspended or at least attenuated during the COVID epidemic, and that's a major threat to this 2030 deadline. So what are we going to do different to pull this off? Well, WHO is very thoughtfully embraced hepatitis together with HIV and STIs, and sort of has a unified approach, because there's so many similarities in how to eliminate these infectious diseases. And so I think that is helpful, especially this idea that we're going to be tackling Hep C with a sort of a public health approach, and not just thinking about it as a one by one in the people who come to the clinic, because we're pretty good there. We cure 98% of people that actually show up and take their medicines. So that's clearly not where the problem is anymore. And so the challenge is upstream. to finding the positives, preventing infection, finding the positives, developing vaccines, and those sorts of things. Perhaps even making something like a long-acting. Can you imagine if we had cabotegravir for Hep C? You know, give one injection and you're cured. That is possible, at least in the thought world and with pharmacologic modeling, and even with some early data. But we're far from the sort of engagement that we need to achieve that. So new tools, new resources, is clearly what's needed to eliminate Hep C. I'm going to stop and thank those whose data I've shown. I've mentioned the Richard's cohort and Mark and what's been shown from there, and then the Alive cohort with Greg Kirk and Jack Aston-Borski, Shruti, and Javier. And then there's some input in here from Yvonne Hooten and John Ward from the WHO. So that's it. I'm going to stop so Chloe has time, and I will unshare. I gained you back 3 minutes, Chloe.
I'll swoop in really quickly. Hi, everyone. This is Cheryl Brinkley. Thank you, Dave. That was really such a succinct, sort of current reflection on what's happening in the world, but also more locally. And I always just get so much out of hearing you speak and your perspective. So thank you for that. And there are no questions in the chat, so I think we'll just move forward. And
Can I ask a question, Cheryl?
Oh, sure, absolutely.
So, Dave, great talk. I was curious about your thoughts on the slide where you show the cirrhosis decrease pretty rapidly. It surprised me a little bit that it would change that quickly. You think some of that has to do with the FibroScan scores being being elevated when people have a lot of inflammation, and then so that that's what we're seeing, and we're not seeing as much real change in the prevalence of fibrosis.
Were you a reviewer too? No, so that's a great question, and of course, cirrhosis doesn't go away overnight. But I will tell you, there's about a 2.4 kilopascal reduction after a cure. And so that is somewhat artificial, right? So it's not like all of a sudden all your scarring went away. But interestingly, that reduction and then the subsequent reduction is correlated with improvements in mortality and the incidence of hepatocellular carcinoma, well, which is why people would die after a cure. So it's not an inconsequential measure. Despite the fact that it artificially reflects the value, the sort of rapid reduction in we did that same analysis with FIB4, which just like the elastography, because the liver enzymes all of a sudden get normal, also drops and shows the same thing. Both measures are strongly improvements in both measures post-SVR are strongly associated with long-term outcomes after cure.
Great. So I think we'll move forward with Chloe's portion of the conference. So I just wanted to briefly introduce, actually, Chloe doesn't really need an introduction to this audience, but we have the extreme pleasure of being able to welcome Chloe to speak on updates on hepatitis B in people living with HIV. And I've said it many times, but personally, I find Chloe does just a phenomenal job of breaking down what I always find to be a complex topic, which is hepatitis B serologies and therapeutics. And one of the things just to sort of kind of keep on the kind of on your mind as we move forward with hepatitis B therapeutics is just the fact that, you know, we are on a mission to eliminate hepatitis B, and we have curative goals in mind for that as well. So it's a really exciting time, and I'm just really excited to hear what Chloe has to say. So thank you, Chloe.
Thank you. Can everyone see my screen? Can you see it, Sherilyn? Can you see my slide?
Yes, it's perfect.
Okay. So as Sherilyn said, I'm going to update you guys on hepatitis B. Oops. Let me see if I can get this to go. Okay. There are my disclosures. And so because hepatitis B is a complicated topic, and I have 20 minutes, I can't talk about everything. I wish I could. So I have boiled it down to talking about diagnosis, prevention, and treatment. And the treatment I'm going to review, the guidelines, which haven't really changed. And I'm hoping I'll have time at the end to just talk about this newer idea that's going on in people without HIV of stopping nucleosides in people who are E antigen negative. Most of what I'm talking about will be applicable both to people with and without HIV infection. All right, so let's first talk about diagnosis. So diagnosis, I used to show this slide that had this, all these complicated list of people who the CDC said should be screened, but it turns out that a lot of the people weren't being screened because who could remember all of these things. And so they have now proposed, this is a proposed recommended screening. It hasn't come out yet, but if you go to the CDC website, you can see their proposal. It's a universal one-time screening for all adults greater than 18 years of age. And they're recommending surface antigen, surface antibody, and core antibody. And this would be, then you could also do periodic testing for people who have ongoing risk exposures, and that would be the people on that slide before with the big X on it, and then anyone who requests treatment. So this should hopefully simplify it, and everybody should, all adults should get screened. And part of the reason for this is because of studies like this that show that screening the general population is cost effective and likely cost savings. In this study, they estimated that the prevalence of undiagnosed chronic hepatitis B was about 0.24%. And they said that they found was that universal screening of adults would be cost saving if antivirals were less than $894 per year, which they are. And then compared with the current practice, the screening would avert, as you can see, I won't read them, but you can read them, these various liver outcomes per 100,000 adults screened. And then importantly, they also found that you would save $263,000 and gain 135 QALYs per 100,000 adults screened. All right, so let's just talk briefly about interpreting screening tests, because I think this often confuses people because there are a lot of them. I think the simplest way to think about it is that if you have surface antigen, your choices are to either have, the patient either has chronic hepatitis B or they're acutely infected. A lot of times you can get from the history whether or not there's a chance that they've been acutely infected. Serologically, you can also distinguish those people because they should have IgM to core antibody. I will say that in people with chronic hepatitis B, so people do have, it's a kind of a relapsing remitting disease, so you do have flares. And when you have those flares, you can also be IgM core antibody positive. So that IgM is not 100%, but it's pretty good, along with a history of knowing if someone is acutely infected. To be diagnosed with chronic hepatitis B, the official definition is surface antigen positive at 2 visits 6 months apart. That's because of this IgM issue. All right, so past infection and vaccination, but in both of those situations, you are surface antibody positive, and you can distinguish people who've been infected in the past because they should also have the core antibody, where if you're vaccinated, the vaccine has surface antigen in it, so all you develop is surface antibody. And then there's this, niggling group of people that's hard to know what to do with, and those are the people with isolated core antibody. So these are people who are negative for surface antigen, negative for surface antibody, but positive for total core. I think that in most situations, based on the studies, these are people who have low levels of surface antibody, and they're right at the cutoff, and sometimes they're above it, and sometimes they're below it. They could also be people who have low levels of surface antigen, and sometimes they're above it, and sometimes they're below it. In terms of should you check a hepatitis B DNA on these people, I think if they're ALT and AST are not elevated, there's probably no reason to. If they're elevated and you don't have any other reason for the elevation, it's not unreasonable to check the hepatitis B DNA, but I don't routinely get it on everyone. I think in our practice, if you have someone who has isolated core and they're on tenofovir, there's probably no reason to check the hepatitis B DNA because they're likely to be undetectable, even if they did have low levels of hepatitis B. So the people with isolated core and low and who have low levels of perhaps surface antigen. If they do have detectable DNA, it's usually at very low levels, a few hundred to maybe 1,000. All right, so if you diagnose with someone with chronic hepatitis B, initial evaluation includes, signs and symptoms of cirrhosis, family history of liver cancer, because that's important for liver cancer screening, then alcohol use. They should certainly be, counseled on not drinking alcohol. The general lab tests, hepatitis B specific lab tests include E antigen, E antibody, hepatitis B DNA, and I think it's also important to get hepatitis D antibody. Because the prevalence of that is probably higher than we think it is based on some more recent studies. Other tests, hepatitis C antibody, HIV obviously is not as relevant in this practice, and then antibodies to hepatitis A to see if they need to be vaccinated. Then some assessment of liver disease, and in the clinic, it's easy to get a transient elastography, so I often do that. Your patient can usually get it the same day if they are able to stay. You can get the blood test FibroSure, or you can get a liver biopsy, which is not done as often. And if you're in a setting where cost is an issue, you could just calculate either the FIT4 or APRI and their online calculators to do that. And those are pretty reasonable in terms of giving you some idea, at least if they have advanced liver disease. So let's talk about HCC screening, because I think that's important also. So what's recommended is ultrasound plus or minus AFP every 6 months. If someone's surface antigen positive and they have either cirrhosis, Asian Black men over 40 or Asian women over 50, first degree family members with hepatocellular carcinoma, co-infection with hepatitis D virus. Co-infections with HIV, hepatitis C, and fatty liver also increase the risk for HCC, but there are no different screening recommendations for that group. But I do tend to screen people with HIV if they're, in the starting around mid-40s or so. All right, let's talk about prevention. So, acute hepatitis B in the United States in some age groups has been rising. So as you can see in this graph, this is from the MMWR in this month. And in the dotted line, so you can see my arrow, and this line right here, with this dotted line, which is 40 to 49-year-old age group, you can see that those people have had an increasing incidence over the past couple of years of acute hepatitis B. As have the people in the 50 to 59 age group. The 30 to 39 age group has been decreasing, but when you take the people from 30 to 49 years of age, that includes about 50% of all acute HBV infections in the United States. And if you add the 50 to 59-year-old age group, that adds another 25%. So those age groups really take account of the majority of the acute hepatitis B in the United States currently. Because of that, the hepatitis B vaccine recommendations as of 2022 have been changed. So this is in the MMWR. All 19 to 59-year-olds and those over 60 with risk factors should receive a vaccine. So now everybody, it's basically a universal vaccine for all adults. And if adults are over 60 without risk factors, they may also receive the vaccine. So hopefully that will allow more people to become vaccinated. In our clinic and people with HIV, it's been recommended for a long time that people get hepatitis B vaccine, so it won't really change your practice, but I think it's important for us to know that there is now universal recommendations for hepatitis B vaccine. So there are more and more vaccines that are available to treat hepatitis B. What we've had generally in the clinic has been Engerix-B, which is the first column there. It's at 20 micrograms per ml. It's at 0, 1, and 6 months that patients get the injection. And the dose in people without HIV is just a single dose. And we'll talk about people with HIV in a minute. There's also the Twinrix available, which is a combination of the Engerix-B and hepatitis A vaccine given at 0, 1, and 6 months. More recently, we've had the hepatitis B available, but it hasn't been available in clinic until just recently. I think probably most of you saw the message from Sheila that it's now going to be available in the Pyxis. And so what the hepatitis B is the surface antigen along with a CpG that activates TLR9. In people without HIV, the advantage of this is that it's only a 2-dose vaccine instead of a 3-dose vaccine. So hopefully increasing the ability to complete the vaccine series at 0 and 1 month. I will say that it's not been studied in people on hemodialysis or in people with HIV. I'll show you the data in a second on people without HIV. And I'll also remind you of the study with this, but it is available in the clinic now. When I asked about whether or not this will be covered by the insurance companies that our patients have, I think it's variable. Some will and some won't, and so you'll have to see if you want to give this to your patients. You'll have to see whether or not it's covered. The most recent kid on the block is PLWHIV, which was actually just approved within the past few months. This is different because not only in addition to surface antigens, it also has antigens to what's called the pre-S1 and pre-S2 part of the hepatitis B virus. This is also a 3-dose vaccine. And it's slightly better in the studies. It showed the 89.4% response versus 73.1% for the NGRX-B. It's also not been studied in people with hemodialysis or in persons living with HIV. So here are the data from the hepatitis B that went into FDA approval. You can see that these were in the younger individuals, kind of middle-aged individuals, and then people with diabetes. And regardless of what age group you looked at, there was better response to the hepatitis B. In the initial study, and it took it a while for the hepatitis B to actually get approved because there was this concern about a risk for increased risk for MIs. So this was a study that was just published in JAMA this month, it was in the Kaiser Permanente Southern California district where they did a non-randomized prospective cluster design analysis where they took 8 centers in their system and they gave all the people in the internal medicine and family medicine practice who needed vaccinations NGRX-B, and they took 7 centers in the system and gave them hepatitis B. And their outcome was a definite or probable MI in the 13 months after vaccine. And the reason they chose the 13 months was because that's what was in the original trial where they showed that difference in the MI risk. Median age was 49. The cardiac risk factors were balanced between those who got the NGRX and those who got the hepatitis. You can see I've listed the rates there for 100,000 person years of MI, and there really was no difference. And you can see in the graph here, the blue line is the NGRX-B, the orange line is the hepatitis B. And this is the incidence of confirmed, what they call type 1, which is definite or probable MI. And you can see there is no significant difference between the two. At the bottom, you can see the large number of people they had in this study. So, I think that this idea of hepatitis B increasing the MI risk has not really played out. So in terms of people with HIV, the DHS guidelines say that all susceptible persons should receive the vaccine regardless of the CD4 count. Any vaccine formulation can be given, but as I mentioned, there are no data on the hepatitis B or the PLWHIV. If you give your patient a recombinant vaccine, they should get a double dose, so the 2 mLs of the NGRX instead of the 1 ml, which is really 2 injections is the only way to get that. If there's no response, if someone gets a 3-dose series and there's no response, then you can either repeat the double dose series, or now that we have the hepatitis B, you could consider giving that instead. The reason that the double dose vaccine is recommended in people living with HIV is really based on this meta-analysis. So a lot of the problems with the other studies is that there weren't enough individuals for them to have enough power to really show that double dose was better than single dose. Some showed it was, some showed it wasn't, as you can see by these various odds ratios, and how some of them crossed 1. In this meta-analysis, if you look at either response at 4 to 6 weeks or response greater than 12 months, or overall, it did favor the double dose vaccine. And I'll just put in a plug to remind people that if you're thinking about giving your patient the Hepatitis B, that to enroll them in the study, I think we talked about last week or the week before that Joyce is running. People, I think the only arm that's still open are people who have failed a prior round of vaccination. But it's a good way to get the vaccine and will help us decide whether or not people with HIV respond the same as people without HIV to 2 doses of the vaccine, or whether or not 3 doses are actually better. All right, so let's move on to treatment. I have 10 minutes. Okay, so I think it's important to understand the phase of chronic hepatitis B, because right now we don't treat everybody. And so when someone first gets infected, they're in this immune tolerant phase where the DNA is high and the surface antigen's high. They're e antigen positive, but their ALTs are normal. And it's called immune tolerant because the thought in the past has been that there's not much of an immune response since the ALTs are normal. That idea is being challenged, which we don't have time to go into today. After this phase, people move on to an immune clearance phase, which is e antigen positive chronic hepatitis B, where the DNA levels fluctuate and an overall decline from where they were in the immunotolerant phase. The ALT levels increase, and people can stay in here. This is the e antigen positive chronic hepatitis B, or they can continue to have declines in their DNA and go into an inactive carrier state where the ALT is normalized, but they remain surface antigen positive. They lose e antigen, develop the antibody. People can stay in this state or then go on to reactivate, either go back and become e antigen positive, or more commonly reactivate as e antigen negative chronic hepatitis B. And it's these two e antigen positive, e antigen negative chronic hepatitis B phases that are currently recommended for treatment. And so who do you treat? You treat people with high hepatitis B DNA, which is defined as 2,000 IUs per ml e antigen negative and 20,000 IUs per ml e antigen positive, along with some evidence of liver disease, either by transaminitis or by getting some marker of the actual liver stage. I'll mention that the AASLD guidelines say that the upper limit of normal for men is 35 and for women is 25. And then anyone with cirrhosis should be treated. And so what do you treat with? The recommendations are Entecavir, tenofovir, or pegylated interferon. Most patients don't want to take pegylated interferon, so it's a choice of either Entecavir or tenofovir. And so people wonder, is one better than the other? And I think that they're both very efficacious, and I've made this little table just to kind of see what the advantages and disadvantages are. With Entecavir, you don't have to worry about the bone or renal side effects, and it's generic, so it's less expensive. The disadvantages, as we'll talk about, it has a lower barrier to resistance in people with prior lamivudine resistant hepatitis B, so not good to use in that group of individuals. TDF is generic and is also efficacious, but as we all know, there's disadvantages of the bone and renal issues. And then TAF is safer than TDF in terms of the renal and bone issues. But as we know, there's an increase in the lipids and potentials, increase in weight gain. So those are kind of, when you think about your particular patient, the pros and cons of each. I will say there is also controversy regarding whether or not there's decreased risk of HCC with tenofovir. I think the jury is still out on that. I don't really have time to go over that data, but that's also an interesting controversy at this point. So in people with HIV, the treatment is much simpler. We treat all co-infected people. The first line should be TDF or TAF with lamivudine or emtricitabine. The alternative is Entecavir along with a fully suppressive heart regimen, and for some reason they can't get TDF or TAF. I often get the question, my patient has been on treatment for 6 months or a year and they're still not undetectable. Should I worry? What should I do? Because we are only treating with one drug, and they're not, that one drug is not as potent as a combination therapy that we're used to for HIV. It does take longer for people to become undetectable, and not everybody does. Because of that, the AASLD suggests that you shouldn't really define the failure to achieve undetectability until 96 weeks of treatment. And at that point, you should ensure compliance. If they're on tenofovir or Entecavir, provided they have no prior lamivudine resistance, if they're on Entecavir, just continue the treatment because the rates of resistance are so low. And we know that not everybody becomes undetectable. If they're on some other L-nucleoside like lamivudine or emtricitabine as the only treatment, they should be changed to tenofovir. And if they're on Entecavir, which I haven't seen anyone Entecavir in a long time, they can be changed to tenofovir or Entecavir. And this is just a visual reminder of why we don't give Entecavir with prior lamivudine resistance. And you can see that in those individuals after 5 years of therapy, about 50% of them have drug-resistant hepatitis B. And that's because with lamivudine, the 2 of the lamivudine resistant mutations are also confer Entecavir resistance. So that if you start with those 2, you only need 1 more mutation to become Entecavir resistant. So it no longer has a high barrier to resistance. Monitoring is every 3 months initially, and then every 6 months when they become undetectable. And then ACC screening, as we talked about. When to stop, pegylated interferon is 48 weeks. With nucleoside and nucleotide analogs, it's usually indefinite. Exceptions are if there's surface antigen loss, and if they're e antigen positive and seroconvert, you can consider 12 months afterwards stopping therapy. You could check also a quantitative hepatitis B surface antigen. If they're less than 100, that's indicative of less likelihood of relapse. And so that would be another indicator that you could potentially stop. All right, so I don't really have a lot of time, but I'll just mention this quickly because I think it's an interesting idea. In the monoinfection world, I just talked about not stopping. There are some data that stopping nucleoside analogs in people who are e antigen negative can lead to a functional cure. The idea is that someone's on the nucleoside analogs for a long time, they stop them. There's some lag phase, and then they reactivate, and then end up during some consolidation phase with either needing to be treated again or having just low levels of virus. But in some studies, up to 20% of people can actually lose surface antigen. And so this is one study of over 1,500 e antigen negative people who stopped treatment, and 13% of them actually lost surface antigen, more so in people who are whites, 36.5% compared to 10.6% in the Asian group. The problem with those retrospective studies is that there's no comparison group of people who continued. So this is one study that was actually a randomized trial where 79 people were randomized to stop and 79 continued. And you can see that the only people who lost surface antigen were those people in the stop arm. However, in another study in Toronto, this was not the case. There was no difference. I will say that this study was mainly Asian and the other study was mainly Caucasians, 80%. So that could also be the difference in these studies. I'll skip this, and I'll just say that because of studies like this, the Asian guidelines actually now say that if you're less than 100, you could stop nucleoside analog therapy with close monitoring, provided you've been on treatment for at least 3 years, and if you're e antigen positive at the beginning, have undergone e antigen seroconversion. So I will stop there and have 2 minutes for questions. Hello?
Thank you, Chloe.
Okay, I didn't know that maybe everyone's gone.
No, that was great. No, thank you. I'm wondering if anyone has any questions for Chloe.
I won't be shy. Hi, Dr. Thio and Sherilyn. So given some discrepancy between DNA and hepatitis B surface antigen, why is it that we're tracking hepatitis B surface antigen to guide therapy and not DNA level, which might be more closely coupled to replication?
To stop therapy, is that what you said?
Yes, you were referring to hepatitis B surface antigen levels for
Yeah.
stopping therapy.
That's
Why wouldn't you use
because-
DNA instead?
Yeah, that's because most people become DNA undetectable. And so it's difficult to determine if you're stopping, it's difficult to determine who's going to really relapse if they're E antigen negative. If they're E antigen positive, everybody relapses. But if they're E antigen negative, it's difficult to determine. And the quantitative surface antigen does seem to be a better discriminator of who is going to relapse once you stop treatment and who isn't.
Thanks.
Chloe, how often is that quantitative surface antigen utilized? Like, when is that really helpful for clinicians? We do have it available now in EPIC. So how do you see what do you see as the utility of that test?
In our population and people who are on treatment with tenofovir anyway, and you're not going to change them, there is no utility. I think it's useful in people who are mono-infected if you are thinking about stopping therapy, if someone, especially after E antigen seroconversion. I think it could also, the one place I do see it potentially useful in our population is if someone just can't tolerate tenofovir for some reason, and you don't want to give them Entecavir, or they already have lamivudine resistance, and or they want to switch to, you know, a long-acting formulation for their HIV therapy that doesn't include tenofovir because we don't have that available yet. You know, you could consider checking it and saying, well, if they're less than 100 and they've been E antigen negative for years, I'm going to try it with, you know, careful monitoring. None of these studies that I talked about with stopping have been done in people with HIV, so I don't really recommend it. But I guess on an individual basis, if there was a huge case for that, then you know, then it's something that could be considered.
Just to note that Kelly did put information about the study protocol. So if you have patients who are HIV positive, who have not been successful with previous hepatitis B vaccine, please consider the study. Chloe, one last question I have is, because we don't have data with hepatitis B in our HIV positives, and that's what the study is about, how are you going to approach your HIV patients who need Hep B vaccines? So vaccine naive, are you still going with our standard, what we've been using, or would you use hepatitis B in that patient?
I think I would talk to my patient about it and tell them that the hepatitis B in other populations looks good. Looks better than actually the NGRX-B, and it's only 2 doses, but that we don't have data in people with HIV. And so if they want it and their insurance will pay for it, I would give it to them, and then we could just check a surface antibody, you know, a month afterwards. You know, the problem is if they're not, a month after their second dose, the problem is if they're not positive, I don't think we can give them a 3rd dose and have the insurance pay for it at this time. So that's the, you know, that would be the only difficult part.
Yeah. Okay. Thank you.
Lori, quick question. What are the guidelines for boosting in both infected and uninfected individuals? And is there any data at all?
So in people without HIV, there's no need for boosting. There's Brian McMahon has done a lot of nice studies in Alaska showing that the boosting is not necessary. In people with HIV, the recommendation is to check surface antibody annually and then give a booster dose if they've lost their surface antibody.
Thank you.
I see that Kelly also has a question about whether or not TAF or TDF is it can be used as PrEP, and the answer is it clearly markedly reduces the incidence of acquiring hepatitis B and probably totally protects you from becoming chronic, but it doesn't prevent you from getting infected, and that's really having to do with the life cycle of hepatitis B, which is complicated, but it is simplified. The TAF works after an infection has been established to stop replication, but it doesn't prevent that initial infection of the hepatocyte. So that's why it can't really be used as PrEP in the same way as with HIV.
Well, thank you, Chloe. I don't see any other questions. So I wanted just to thank you and Dave for just always giving us so much current information, and I'm very, very grateful to both of you. Eileen, did you have some final comments?
No other announcements. Thank you so much
Wonderful.
to both of the speakers, and look forward to seeing everybody next week for